Good afternoon and welcome to today's webinar on defining results-based care transition processes. Our presenters today are Mike Levinger and Tim Perkins. And with that, Mike, you can take it from here.
Thank you and good afternoon, everyone. We're excited to be able to talk to you about care transition processes. Today, we're going to start by outlining the background of care transitions processes and look at the root causes of ineffective transitions of care, and then describe and discuss some of the structured approaches to improve care transitions and look at 8 key transition areas that you should review and how you can use those to improve care transitions. And of course, we'll end with questions and answers and welcome any thoughts or questions that you might have for us. By way of introduction, Digital Collaboration Solutions is a consulting and services company that provides care coordination, collaboration, and patient and provider engagement solutions. We work with a wide range of participants in healthcare, including hospitals, payers, and other types of organizations in healthcare to understand how they can improve care coordination using an integrated approach that recognizes that success is the result of understanding how processes implemented by the people in healthcare and supported and aided by technology can deliver results. We have a very results orientation and look to say, how can we help you to measure where you are now and measure the results, and look and saying, how can particular interventions or strategies help you to achieve those results? So DCS's approach is to start with a quick survey of your existing processes so that you can and we can help you to quantify your risk, the impact and cost today, both financially as well as in care quality and patient experience, and then estimate the improvements that can result from implementing a strategy, and of course estimate the cost to implement that strategy so that we can help you to see a return on investment in both dollar terms as well as care quality terms, and judge whether a particular strategy is the right one to take. And we can work closely with clients to help them, and today we want to walk through and show you some of the ways and approaches that we might do that. Tim, why don't you take it from here and talk about care transition processes?
Okay, good afternoon, everybody. So a little background first before we dive in. Care transition processes, we know that they aren't getting any easier. They're getting more complex, especially as the places where patients receive care and as the continuum of care continues to branch out. We also know that Medicare is now penalizing those hospitals with poor transition processes, and they show themselves through readmission penalties, 30-day readmission penalties, value-based purchasing penalties, and also subjective patient quality scores through HCAP. So those are some of the ways in which previously transitions of care you could get away with some, but now it's getting a lot harder and a lot more important to stay on top of. So how do we optimize care transitions? Well, it's the classic of it's a combination. It's not just technology itself. Putting in a new EHR is not going to solve your problem. It's not just about the people, although they're the critical component to it, but it's about how the people and the technologies work together. It's the process that glues it together, and it's all the members of the care team and the patient and patient's family working together to provide good, smooth care transitions. So which of these are effective and how do we get started? So we're going to take a look at some real-world processes that are working for today's hospitals. Some workflow changes that have a big impact. Right now you're probably doing most of the things we're talking about, but it's those things that are not being done or maybe being done in a halfway manner that can be improved that make a big impact. In many cases, it's about doing things you're doing today a little bit differently can have some big impacts. And then, of course, there is a role of technology in here. It is not the thing. It is one of the main things, but not the thing. And then how do you get there? Okay, so we all know benefits of good care transitions, right? Your readmissions are going to go down. Your rates and your penalties will go down. Financially, you will be a much stronger acute care organization. Your reduction in bounce backs, people coming back in the door at 15 days, will go down. That means better quality care, better penalties, more room and time for other patients. Reduction of length of stay, that's one of the overall measures. How quickly can we get you in and out and keep you out of the hospital? Improve patient sat, that's now through HCAP, among other things. That's what's going to materially impact your revenue. Are you getting higher value-based scores? Are the families happier? And is the staff satisfied? If the family is happier, next time they need medical care, they're going to come to your institution. And is the staff satisfied, or they feel sometimes they're just on a revolving door? Satisfied staff provides better care. So today, if we take a step back, 75% of hospital patients are able to go home after discharge. And that's good. But 25% go elsewhere. And they're going to rehab, they're going to other acute care, long-term facilities, skilled nursing facilities, etc. So these 25% really are the more complicated ones. So as we all know, although we'd like to think so, no two transitions are the same. It's a complex ballet of interactions. Also, there's more home-based services than there's ever been, and more post-acute care services without requiring admittance or admission to another facility. So those have come up in recent years. So how do you coordinate all of that? If we look at a transition to care, there's two basic definitions we should be looking at. The first is the CMS Medicare definition, and that's, let's say, CMS-centric. They are worried about the movement from a patient from one setting of care to another setting of care, predominantly from acute care to rehab or long-term nursing or short-term nursing or skilled nursing facility. The Joint Commissions, I like this one a little bit better. This one is more about more holistic. It includes home. So how do we move the patient from one care setting to another, which includes the home? And I think that any successful transition care program over time really needs to embrace the Joint Commission's definition, which is a little more holistic for the patient and their families. So let's talk about what some of the root causes of ineffective transitions of care are. The Joint Commission did a good study here, and they said, look, it breaks down to three main things: breakdown in communication, breakdown in patient education, and breakdown in accountability. Those are the three root causes of ineffective transitions of care. It's a very good study. I recommend it highly. Communication breakdowns. Handoffs aren't happening properly. That providers themselves aren't communicating amongst themselves effectively or completely. So they're not communicating among themselves, with the patient, or to those taking care of the patient, the family, the friends, the downstream providers, the different types of providers. It just doesn't happen well. The handoffs don't happen well. And the Joint Commission says if you look at problems, 80% of the time, miscommunications during handoffs is one of the main reasons that you're having issues. So you've got communication methods, verbal, recorded, are ineffective. They're just not, people aren't speaking clearly to each other of the key facts that need to be sent across. Recorded helps sometimes. Written, and even in a computer, in an EHR system, you find that there's missing pieces. Communication is not done in a crisp, thorough manner. And when you talk to people who have done transition of care improvement projects, they say one of the fundamental things they sit down with is they say to the sender and the receiver of handoffs, what are you sending and what are you expecting to receive? And that when they list those items, there's often a mismatch. So it starts there. Let's get the people sending and receiving on the same page, and you have a beginning of to address the beginnings of how to address the handoffs. Another study showed that discharge summaries, found that interesting, that 2/3 of the time the discharge summaries aren't getting to the primary care provider for the follow-up appointment. And when they do, Even then, it lacks key information. So I found this fascinating. And we could do a lot of work on discharge summaries alone, effective, timely discharge summaries, and that would be a project in and of itself to improve communications and effectiveness of transitions of care. Patient education breakdowns. Patient hears what they want to hear. They get different members of the family and the patient. They hear conflicting recommendations. They don't understand the medications. They're unclear about the instructions. They are left out of the picture sometimes. You can't get all members of the family at all times. You can't get them all to agree on things and understand what happened. Lots of times, especially in a Medicare setting, we're dealing with a patient that the acute care physician has just met, and they don't understand their cognitive abilities. The cognitive abilities may be degrading because of age. No matter how many times you tell them and they nod their head, they just don't get it. And the patients aren't doctors. They lack understanding. So you may try to explain the fact that you have a particular condition. They don't quite get it. They don't quite understand it. So again, other misunderstanding of what they're being told. Good study here on the right-hand side is that the 65 years old, they asked them, yep, I had a good understanding and perception of my discharge instructions. And then they quizzed them on it. And 40% of them were unable to tell the researchers why they were in the hospital in the first place, and over half of them didn't recall their instructions about their follow-up appointment. So they think they understand it until you ask them about it, and then they show that they really don't understand it. So this is a part of human nature. It's also a part of the fact that majority of our resources are going toward patients 65 and over, and when you get into that realm, you're going to have some of these issues. But all this contributes to breakdowns in patient education. And finally, accountability breakdowns. Who owns the patient? Where do they own the patient? Where do they begin to own the patient? Where do they hand off that ownership to somebody else? And who owns the patient overall? So it's hard. No one's really taking responsibility to assure that we have care coordination across various settings and providers. ACOs are beginning to do that. The primary care physician is beginning to be identified as that person, both on paper and financially. But many times the primary care providers aren't identified, and when a person walks in through the emergency department, we don't always know who the primary care physician is. And if they walk into the ED and they're taken up for heart issues, they deal with cardiologists. Many times the cardiologist won't even know who the primary care provider is, much less attempt to identify him to send them discharge instructions and information. So steps aren't taken to ensure that the knowledge and the resources are going to be available to the PCP, and even what's going to happen when the person leaves the hospital. They're out of my hospital, great. Who's the PCP? Don't really know. So a lot of accountability breakdowns. Who owns the patient? Interesting study, 9% of physicians have admitted to turfing patients, even within a hospital. Person comes in, they have a heart issue, but they also have a kidney issue. You know what? Let's take care of the kidney problem first. Put them over into the, into a different service. 9% of it admitted to doing it. We think it might be more. There's also an issue of people turfing between hospitals. So accountability breakdown. You take all three of those together, and a myriad of issues each one of those represents, you wind up with a degrading of the transition of care. So how can we improve transitions to care? Well, there's already a lot of models out there. Anybody can go out there and read about Boost and RED and GRACE and the Care Transitions Project, the bridge model to care transitions. There's a lot of them out there. They all have a bunch of things in common. So you may have one flavor or another, but what we found is that most people will come up with their own stew of transition of care, based a little on this model, a little bit on this model, a little bit about here's how we've always done it, and then they come up with with what they believe works for them. Although what we're finding based on research, is it doesn't always work well. So 3 basic types. When you look at the models, you say, look, you work with the patient before they're discharged, so work with them on patient education, on planning. Is someone going to be at home? What can you get to the appointment by yourself? Working on MedRec, what are you taking at home? What's your new medications? What your new medication regime is going to be when you get home? And make sure you get that follow-up appointment. You get that follow-up appointment as quickly after discharge as possible to make sure that the medications are working, your new regimen is in place, and to try to keep you out of the hospital for at least 30 days. Then there's the post-discharge interventions. Once you're out, how is the patient education going? Are you learning? Are you taking your meds? Can you get to the appointment? Have you gotten to the appointment? Are you taking home care, home visits? Are they working? How are you feeling? And then the bridging interventions. Some institutions, especially more on the accountable care side, as people make the transition there, they are embracing transition coaches, active care coordinators, patient-centered discharge instructions, and really how do we connect those islands of care with a transition coach or someone who's taking responsibility for the long-term continuity of care for that patient. We see more and more of these coming on the scene. So the Joint Commission, I won't spend a lot of time on this, but they recommend 7 foundations of effective transitions. And this is really good basic information. Is the information being transferred properly between all the players? Is the patient and the family involved? Are they engaged with the care of the patient and the loved one? Medication management. Medicare believes that that's 11-12% of the problem right there. Billions of dollars lost on prescriptions not being filled or being improperly filled, people not taking their meds properly, mixing, matching, and just a lot of issues there. Medication management is a huge issue. Is the transition planning happening in a timely manner? Is it effective? Are we identifying patients and clients at risk when they come in? Are we taking the time to do that? Are we really collaborating and coordinating across multidisciplinary? Are the caseworkers working with the physicians? Are the physicians working across services? Are the nurses involved? Are the primary care people involved? OT, PT, visiting nurse? Are all these people on the same page? Because it seems like they get a subset of information to run with, do the best they can, but the overall picture, things get dropped. And of course, the steady, and you see in any major change, you need leadership support. So is management supporting you? Are they saying, yes, this is important, yes, this is more important than other things? Or is it just, yeah, work on that when you can, and you'll get, leadership gets what it supports. So if they don't support it, they won't get the results they hope for. So here's 8 things to review. Right out of the gate, you can say, okay, all that's good, all that's interesting, but what do I do? Here's 8 processes, 8 areas to take a look at, and we work with our clients to say, look, let's go through these. Some of these things you might be aces on, some of these things you might never even have thought of. Usually what happens is everybody's doing more of one, less of another, and that's a good way to start the conversation and get a review of what's going on, care transitions in your facility. How's your multidisciplinary communication, collaboration, coordination going? Start at admission, go through transition, go to post-acute, go to the maintenance of the patient, and in some cases it swings back around again. But look at that whole continuum, not just from when you walk in the doors of my hospital to when you leave the doors of my hospital. That's not good enough anymore. You need to coordinate broader across the whole network, and not necessarily your network, but the network from the patient's perspective. So how's the care team doing? Who is the care team? Not just the physician, the acute care physician, not just the acute care nurse, it's the pharmacist, it's the in-house pharmacist, it's the pharmacist at Walmart, it's the social worker. Could be the social worker in the hospital, could be a social worker in the community or in a clinic, right? How is everybody collaborating, coordinating effectively around the patient, not around the facility or around the service, but around the patient? Good case managers will tell you that discharge starts at admission. So same thing here. How does a team start at admission throughout the patient's hospital stay and then post-acute and into maintenance? And in some cases, predicting or preventing further admissions to the hospital. When it's done well, you're spending money effectively, good quality care. You're keeping the patient out of the hospital and working in the community. So in addition to just rounding and meetings with the patient, how active is your patient education? Are you really working with the patient, or are you dropping off pamphlets and saying, read this? So is it a check-the-box item, or are you really actively committed to getting that captive patient to understand what's going on with their situation and how to improve it or how to take control of it? In some places I've seen there's a literature drop. Take a look at this, and no questions are asked. So it's, are they doing it? Yes. Are they doing it well? No. And I think the results will bear out in terms of 30-day readmissions, HCAP scores, etc. How's the clinician involvement going? Is there clear accountability during all points of transition? Do we know that the sending and receiving clinicians know what they're sending and know what they're receiving? Are they aligned? Right? Is there a clear, defined handshake where every party gets what they expect to get? Okay? Or do we know every time they exchange information who is sending and who is receiving? Something as basic as that. I got a fax from the hospital. Who from? Don't know. Dr. Smith. Which Dr. Smith? We have 5. I have no way of getting back to that person. Now I have to spend an hour trying to figure out who sent me this fax in the first place so I can get my question answered. In most cases, people give up after 7 to 10 minutes. Make a guess, which isn't not good for them. It's not good for the patient, especially. Every point of the transition, right? They need to be identified, such as the primary care physician or the nurse practitioner. So you're talking to the patient, who is responsible. The primary care physician is going to do your follow-up. You're going to have a visiting nurse come out and visit you every day. You're going to come back and check with your cardiologist in 15 days. Very clear to the patient, because you don't know how many people they're dealing with. They do, and they need to understand what their relationships are and what's expected of them in the bargain. Comprehensive planning and risk assessment, number 3, during the hospital stay. Is everybody being risk assessed when they come in? How are they being risk assessed? Do you have your own methodology? Are you using a LACE methodology? Have they been in the hospital within the last year? If they have been, I would advise that they're automatically a high-level risk. That's good guidance from CMS. Are you planning their discharge as soon as they come in? What do we need to get this person treated and discharged properly? Right? What kind of risk factors are there? Socioeconomic risk factors involved here. People are now beginning to understand that more and more, especially in some inner-city hospitals that feel like they're getting unduly blamed for 30-day readmissions. Well, we gave good care, but the patient doesn't understand my language. The patient doesn't have transportation. The patient doesn't have money to be able to afford their medications, so they're not taking the medications, so they're coming back in 15 days. There is some really good studies out there, like the Camden study and the Camden work, which talk about the impact of socioeconomics on the patient and their caregiver's ability to adequately care for the patient. So are you looking for those things? Are they actively being sought out and dealt with? If not, they will come back to you by walking back through the door. And you have to make sure that at each step in the process, what the risks are. I'm going to let you out, but do you have medications? Do you have the medications you need? I can give you 30 days of medications. From here, I can do a meds to beds, and that's great. But what happens on day 31? What can I do? How do I make sure that you're hooked into the Walmart or the Walgreens, right? How do I make sure that happens? We've got to be thinking ahead, and that's part of what coordination is going to be able to do for me. Now, I don't lose touch with you when you walk out the door. There's a continuum of care that needs to be considered. Otherwise, they will walk back in the door with all the attendant penalties and quality issues. Standardized transition plans, procedures, and forms, especially in a teaching hospital. If you're changing floors every 6 weeks and they do something different for discharge and transition to care on every floor based on services, then that's not good. So especially larger organizations, are you doing it the same way every time, every place? Are you reducing variability in the transition to care process? Are you really doing a good job at writing down your active issues, your diagnosis, your discharge plans? A lot of what we see is just because it's in a checkbox in an EHR doesn't mean it gets done well, or it's a couple of words. It needs to be done well. It needs to be, especially in a teaching hospital, the attendings need to actively audit, the residents need to audit the process and make sure that it's being taught well and adhered to. These are downstream to the other folks who need to deal with the patient, right? So is there a good transition care plan? Is there a good discharge summary? Does the patient know who to call if there's a problem? Is there somebody there to call beside just an answering service if they have a question? And are you reaching them the way they want to get reached? Language, device of choice, text, phones, phone calls. How do they want to get communicated with? We have a much more sophisticated audience now with much more sophisticated tools. So it's time to use those tools in order to reach the patient properly, in order to make the transition stick to get the desired results. Standardized training, very important. And it begins in medical schools and nursing schools. This is kind of a longer-term issue by the Joint Commission. How do we make sure that transitions elements are really included in nursing schools and medical schools, including risk assessments, and that these skills are taught and not just something that get picked up when the nursing and house staff hit the floors. So very important, standardized, and from the start, this is a part of medicine. Good transitions are a part of practicing good medicine. Timely follow-up, can't forget that. All the studies point to the fact that they have good timely follow-up when a patient comes out of the hospital and I've done a clean handoff to the next person in line who's going to help this patient, and we get to follow up on their care and check on their meds and look them in the eye and check their vitals and see how they're doing and ask how they're doing and have they understood the patient education. That all positively impacts coordination of their care and keeps them out of the hospital, and frankly makes them a happier client, happier patient, impacts the HCAP scores, but their health is addressed up front in a proactive manner. When they are readmitted, and they will be readmitted, there are 30-day readmissions. I doubt we'll ever see it go to zero. There'll always be some 30-day readmissions. The question you need to ask yourself is, instead of trying to ignore it or deal with what you have to deal with, embrace it. Understand why. Why are you back? What happened? Did you not understand education? Do we have a breakdown in education? Do we have a breakdown in communication on accountability? Did you not take your meds? Did you not understand your meds? Did you not have transportation to your follow-up appointment, therefore you couldn't do your follow-up appointment? and therefore you got into trouble and you had to come back. Why? And that curiosity on each one will gain insights and valuable knowledge, and you'll be able to create countermeasures to address those issues and keep those patients healthier longer and keep them out within 30 days. All of that, no matter how mundane it might feel, like, oh, I didn't have a ride to the appointment, impacts the quality of care. So something as simple as that has a big impact on the back end. Does it have to do with medicine? Not directly, but indirectly it has everything to do with medicine. So we have to actively embrace that culture. You've got to measure it. You can't fix what you can't measure, especially when you're dealing with scale and volume. So when you have hundreds of patients, 50, 60, or 100 leaving the hospital every day, you have to understand how to deal with scale, and also one of the benefits of automation is the ability to create great amounts of data. Make sure that data is accurate, and it's very useful for you to collect and measure the transitions of cares. Starting with readmission rates, how long does it take to discharge a patient? When do they come back? What's the appointment adherence? What am I doing about no-show appointments? What's the how many blank electronic discharge summaries are out there? There are a number of different things that you can measure and measure effectively and stay on top of. And you'll be able to see whether you're making progress instead of just a quarterly or yearly HCAP summary where you might be surprised at the results. You should never be surprised at the results if you're measuring the information along the way. Sounds simple. It's amazing how many people don't really do this actively. So very quickly, we've gone through 8 things that you can do. I'm sure that some of the things you said to yourself, yeah, we do that. Oh, yeah, we kind of do that. But have you really systematically gone through all of them, looked at them and said, yes, no, we do this well, we don't do this well, we're not really measuring this, we're not really committed to this, we really don't know this, and oh my gosh, we've never thought of that. There's all kinds of every place is a little bit different, every organization. So our recommendation is a good place to start. There's some best practices. This was based on a study that was done where they looked at a bunch of different hospitals, and they looked at root causes of bad handoffs, and they went down the list. And it's amazing how many root causes came out. For example, providing bad information on handoffs, DNRs, and MRSA infections, and things that you would expect to be there that just weren't there. Information and things that happened because the basic information wasn't being handed off. They all had that as one of their root causes. And all this it's a good way to start. But best practices are useful, but one size does not fit all. So you may look at that list and go, yeah, we do that. We got that nailed. And you may look at that and you say, yeah, we kind of do that, but we don't do it as well as we could. And we look at things and say, oh, no, this is definitely a problem for us. However, it's not as simple as saying, we do all these best practices and everything will be fixed. Embrace them, use them as a guideline, but understand that they are just that. They're a guideline. So our recommendations and takeaways, this is more about process and how people and technology work together than about just adding a person or putting in a new system. It's really about understanding the interrelationships of the 3 areas. That's how you improve, how you measure, how you identify, and how you improve. Change is never easy. People prefer to do things the way they've done it in the past. To really impact transitions of care, you have to be willing to dig in. You have to really be able to confront and improve those breakdowns that we talked about. Communication, patient education, accountability. Who owns the patient? Just start by sitting everybody down and saying in a transition, what do you think I'm sending? What do you think you're receiving? We've given you 8 areas to review. That's plenty to get started with. Understand best practices are great guidance, but they're not the end-all, be-all. But guarantee you, if you strive for the best practices, you're going to find a lot of other things along the way that are going to improve transitions of care for you. And you really need to understand and measure your existing processes. We've got care impacts, staff impacts, and financial impacts. And Medicare has made it very clear there's very direct impacts now that were indirect previously that are much more direct now than they've ever been before. And if you think that they're going to go away, then I hate to inform you that they will not. They will just get stronger and be more stringent and take a bigger bite out of your revenue until you pay attention to them. And that is happening, and it will continue to happen. Yes, we understand each transition of care is complex. You can't treat every case the same, but you can put a good process in place, standardized process, and you can address, you'd be better suited with better tools to make each transition work the best possible for the patient and for cost effectiveness. It will fight you. Lots of interesting stories about the unique combinations of transitions of care. And it's about the approach. You need to dig in, you need to be deliberate, you need to understand it, define it, measure it, get the folks behind it, come up with some good ideas, implement it, measure the implementation, go back around again. So it is, how do you address it, look at it, measure it, improve it, measure it again? How do you incorporate everybody who implements the process? This isn't just one or two people running around. It needs to be everybody involved in the process, sharing the information, learning from it, getting better together, and you show results continuously. That's how you begin to bring the people on the edges around, the people who don't really want to get involved. When they start seeing the results, they'll want to get involved. So it's all part of an overall effort to measure, define, measure, implement, measure again. So there's a lot to work on there.
Well,
Mike?
Tim, thank you for a great discussion of transitions of care and how to optimize them in a hospital or healthcare setting. As Tim said, we're happy to provide you more information, including copies of the materials that we went through today. Both Tim and my contact information is on the slide now, or you can get it on our website, thinkdcs.com. We appreciate your time this afternoon and look forward to any other questions you have in the future. Thank you.